Thank you, everyone. Do you guys see anyone else outside? Just shoot them in. All right. Well, we're very glad and proud to have the opportunity to have Dr. Don Berwick with us today. Dr. Berwick is no stranger to many of you, but we're especially glad to have him here for the second annual Healthcare Champion Award, which is an award series that we started last year. The intent of this award is really to recognize an individual who has made an extraordinary contribution to the field of healthcare, somebody whose actions and whose ideas have really inspired change in our healthcare system. And there's nobody more deserving of that award that we can think of than Don Berwick this year. You know, changing the world takes a movement, and it often takes a lot of people behind that. But so often there are a handful of people, just a few people, that catalyze that movement by creating a vision and by inspiring people to rally together around that vision. These kind of people are known to all of us, and they have an impact that goes beyond what we can measure, because not only do they change what we do, but they also expand our sense of what is possible in the world. Don Berwick has been just such a person. After training in pediatrics and in public policy, he began practicing medicine, and it was through that experience that he began to see firsthand how the system was not serving patients. Now, undoubtedly, there were many people out there who saw the shortcomings in the system that Dr. Berwick saw. But what Dr. Berwick did is he began talking about quality improvement before most people even really knew what that meant, and before many people had taken that up as a charge. And he began thinking in particular about two things: about how we could improve health and healthcare, but also about the role that we as physicians should play in that transformation. In the late 1980s, Dr. Berwick started the Institute for Healthcare Improvement with a goal of redesigning healthcare to achieve better health, better healthcare, and reduce costs. In the last 30 years, IHI has done tremendous work. They have launched a number of groundbreaking initiatives, including the 5 Million Lives campaign, which created a national network for quality improvement and reduced needless complications and deaths. IHI has not only taken its knowledge to hospital systems across America, but it's gone well beyond our borders and has helped to build and inform systems all across the world. What began really as an idea from one man in the 1980s has now grown into a transformational movement that's improving lives and healthcare across the world. Now, Dr. Berwick has been showered with many accolades for his work. I could spend hours going through them, but I will suffice it to say that these awards have come from a number of different people, from community organizations, from medical societies, from groups focused on quality, and also from international organizations. Dr. Berwick was elected a member of the Institutes of Medicine, and he is also, in 2005, was appointed by the Queen of England as the Honorary Knight Commander of the British Empire, which I thought was a pretty cool title. This award he received from the Queen in honor of his work with the British National Health Service. Now, it's no surprise that Dr. Berwick was then asked to lead the Center for Medicare and Medicaid Services. And he was asked to lead it through its most important period since the creation of Medicare and Medicaid, and that was during the implementation of health reform. Now, much of the implementation of the ACA actually went through this Center for Medicare and Medicaid Services. And during Don Berwick's time as the administrator of CMS, he oversaw much of this process. Now, thanks to his dedication and to his hard work at CMS, we're now seeing many of the benefits of the ACA rolled out through CMS. Everything from the increased financial assistance that seniors are getting to pay for prescription drugs, to the free preventive services, which millions of seniors are now receiving, to the groundwork that's being laid now for the expansion of Medicaid, which will bring millions and millions of Americans into the coverage net. All of these and so much more have taken place because of the work that Dr. Berwick has done and because of his leadership at CMS. Now, it's possible to learn all of this about Dr. Berwick by actually going to any number of websites and reading about it. But what is a little harder to find about Dr. Berwick, and what's a little harder to appreciate unless you've actually heard him, is just how gifted he is in his communication skills. I feel privileged to have had the opportunity to have heard Dr. Berwick speak a few times, and I can tell you from firsthand experience that few people communicate with the clarity and with the moral urgency that he does when talking about healthcare reform. The last few years have made it undeniable that this kind of communication is critical. In fact, it's important not just with the public, but this kind of communication of what health reform really is, what it does, what it means, and what we should do about it is so important with our own colleagues, with other physicians. Dr. Berwick is actually able to talk about health reform so eloquently, not just as a technical change in how we deliver care, but also as an opportunity that should unite all physicians behind a moral calling. And in fact, it is this moral calling that is at the heart of what we do here in Doctors for America. This deeply ingrained value that places patients and the well-being of patients first and foremost of our concern. This is what's inspired so many of us to come together in this organization and around the cause of moving health reform forward. Finally, on a personal note, I'd like to share a brief story about Dr. Berwick that took place a couple of months ago. Now, a few months ago, Dr. Berwick came to Brigham and Women's Hospital, where I work in Boston, and he gave grand rounds there. Now, grand rounds at the Brigham takes place at 8 o'clock in the morning on a Friday. Some might argue that's the worst time in the world to try to schedule an event like that. It's early in the morning, it's on a day which you probably want to take off from work. And true to form, in general, at grand rounds, you can often find a few people who are falling asleep. You can find a few people who leave early or come late. And you can often find, as some of our folks here will attest, who have been there firsthand, you can often find residents who are there because they want to learn, but quite stressed about the fact that they have to delay rounds for an hour and half their mind might be there. But the day that I sat in grand rounds, when Dr. Berwick spoke, it was standing room only. And it was an audience of hundreds of people who were transfixed on what he had to say. Now, people there were intrigued by the lessons he had to share and by the experiences that he had had. What did he learn in Washington? Some folks asked. And what insights can he bring back to us? But as we spoke afterward with people who were there, what I realized is that many of them were actually most intrigued and most struck by his integrity and by his call for moral action from the physician community. And this, in the end, I believe, may be one of Dr. Berwick's most valuable contributions to healthcare, which is his calling on our profession to take the hard work of improving the healthcare system as a moral opportunity, one that we are in fact uniquely positioned to address. The message of Dr. Berwick is that we are not just doctors for individual patients, but that we are and that we must be doctors for all of America. Dr. Berwick, we appreciate all that you have done for healthcare and for America. We appreciate all that you have done, in fact, for our profession as well. And we offer the Doctors for America 2012 Health Champion Award to you in recognition of your integrity, in recognition of your extraordinary contributions, and in recognition of your vision for the future, which continues to inspire us all. Please join me in congratulating Dr. Berwick.
Thank you so much, Vivek, and thank you all for your warm reception and your good wishes. It's just such a pleasure to be with you. And, I feel so deeply honored by this recognition from an organization I admire so much. Vivek mentioned inspiration. I assure you, the inspiration flows the other way. Just watching the energy of DFA over the time I've known it, and so many in the audience I know, it just gives me all the hope I need. I'm very, very grateful to you. You are bringing energy and leadership at a time that's really, really needed. I want to just take a couple of minutes to put this back in context. You hardly need my encouragement. You've got all the fuel it takes, but I just want to make sure you've got your tank completely full. This country is in the midst of something majestic. That's what I called it when I left CMS, majestic. As you know more than any other group of professionals in America, we're the only country that has not had healthcare as a human right. And now, at last, we're starting to make a movement toward closing that unacceptable gap. The Affordable Care Act's the platform, and it goes a long way, 32 million people covered, if we stick with it. I think it needs to be said that that does not cover absolutely everybody, and the job will not be done until every single person in our country has the health care they want and need, but what a massive and important step is in that direction. The problem is that step is at risk. I frankly think the risk would be there even if the Affordable Care Act had never come into being and we weren't covering the additional 32 million people, because we have a healthcare system that doesn't function properly. That's been the focus of my career for 30 years now, trying to help not just our country, but any country that I get a chance to work with to understand that healthcare can perform better than it does. The possibility of perfection in healthcare is real, and the reason we know that is because of examples, organizations, processes around the world that approximate that. They get closer and closer to the kind of care we want to give: safe, effective, patient-centered, timely, efficient, equitable care. Those are the 6 dimensions of Institute of Medicine in 2001. Safe, nobody gets hurt. Effective, we can give you all the care that can help and none that won't. Patient-centered, the patient is the boss, we're the servant. Timely, delays, uninstrumental delays are gone. Efficiency, getting waste out of the system, especially one that is stealing resources when it wastes from other social sectors. And equity, in our country, that means mainly closing racial gaps in health status. All of that's possible. Every single step toward progress is possible. I've been speaking most recently about the system that just won the Malcolm Baldrige National Quality Award. The award was given last week to the South Central Foundation, the Alaska Native system in Anchorage, Alaska, that has the NUCA system for primary and specialty care, very stressed population. The NUCA is a completely team-based, highly coordinated system based on electronic medical record. If you're a NUCA patient, you have a doctor and a nurse and a nutritionist and a physical therapist and a behaviorist and a social worker, anything you need. Team is the name of the game in NUCA. And if NUCA, starting with a cost per capita that's far below what the American average is, they're now down 50% in hospital admissions, down 60% in specialty consultations, down 20% in primary care visits, and with a set of metrics of quality and satisfaction with staff and patients that would be enviable for any system in the world. Nobody can say that we don't know what healthcare ought to look like. This could be a great story unfolding in our country. Healthcare is a human right coming into port, and the redefinition of care itself through improvement and change to make that possible, because we know what to do. It could be the best possible story: better care, better health, and lower costs for everyone. The problem is it's not on the rails, and that has to do with circumstances in our country that don't have a lot to do, in first instance, with healthcare itself. Circumstances like the economic pressures, macroeconomic pressures that are threatening the vitality of our country: the wages of labor, the funding of museums, the ability of government to discharge its duties, coupled with what the old-timers told me when I was at CMS is an unprecedented level of polarization, rancor, and failure dialogue among the leaders in public policy today. I don't know why we got there, but that's where we are right now. And probably nothing on that side of the coin impressed me at CMS so much than the inaccessibility of meaningful discourse about how to solve these very important problems of justice and excellence in healthcare. The consequence has been very, very costly. Right now, the immediate one that has us concerned is the threat to this very important statutory platform, the Affordable Care Act, which actually gives us a basis for making the progress in justice and equality that I'm talking about. Got plenty of provisions that allow that to happen. But it's actually a longer-term issue about whether we have the confidence and the optimism in the country to achieve the health care we want. The The immediate risk is to the law, I guess. But the real risk isn't the law, it's to the confidence and optimism of the public. Because unless we have an American public that believes it can have health care, justice, and excellence at the same time, at a price it can afford, we won't have the political will to do it. The consequence of failure is dire. The consequences aren't just for health care. Health care can't be what it can be. Then children suffer because schools suffer. Our commerce suffers because our roads fail. Arts suffer because we can no longer afford the museums and the symphonies. Things unravel in a way that I don't welcome at all. So how to recover public trust in political momentum? It's right in this room. I think that there's an unparalleled opportunity right now in this country for a restoration of public trust and optimism in what can be made of healthcare through leadership of professions, not just physicians, all professions that are involved in healthcare. The public is hungry for hope. It's hungry for somebody who doesn't look confused, somebody who can say, there is a way. And they will believe you above all others if you are confident and articulate that to them. Hope, confidence, changes. And of course the center is what Vivek mentioned, that it's all about patients and families. It's the answer. The way to have health care that meets needs at a price we can afford is to focus completely on need and on little else. I think professionals are in a position to make that case. The more you study the possibilities, the more effective we will be as communicators. But man, I welcome this million campaign and imagine tens of thousands of you out there finally telling the story that needs to be told. I'm very, very grateful for your leadership, grateful for being for now my grandchildren who have become very important to me in that world of fixing up. I read the other something I'd never read before by Saint-Exupéry just the other day, that we don't inherit the world from our ancestors, we borrow it from our children. And keep that in mind. Thanks. Suggested that maybe we want to ask you some questions. Everything's fair game. There's no such thing as a bad question. Just bad answers. So go right ahead, please. Yes, sir.
Chris.
Is it on? Chris Hughes from Pittsburgh. Thank you so much for your service to the country and the medical profession for all that you do. Really appreciate it. So about 10 years ago, the American Board of Internal Medicine Foundation, the ACP Foundation, came out with the Charter of Medical Professionals. Two of its three tenets were social justice, access to care, just distribution of finite resources. Every major medical organization on the planet, as best I can tell, has adopted it, including the orthopods, the AMA, the anesthesiologists, and so on. Why is this still such a controversial subject? Why, frankly, did you get in so much trouble for saying, we have to be fair in how we distribute resources?
I don't think there's a simple answer to that, but let me give you two thoughts. One is, maybe this is just another way to say what you said. We seem to have become a bit uncomfortable, for reasons that are not clear to me, in articulating the moral vocabulary. We are not saints, but we're good. And the duty to heal and to have a society that takes care of people who need to be taken care of, who someday might be me. It needs to be said, it needs to be spoken. And I think that somewhere along the way it became, maybe it didn't hold too well or something. But I think the moral vocabulary is to be recovered now. I think we must remember the patient first. And I have said, and I believe this, that I think we need to remember the poor first among patients. The commitment to people who don't have enough is crucial to a moral society, and we need to recover that vocabulary. And I think by articulating it and you know, from your heart, you will be leaders, and people are waiting for that. That's part of it. The other's a little harder edge, which is, I mean, it's one thing to say what everybody else ought to do, but it's another thing to ante up. And one thing the professions need to show, and I'm not criticizing professions, I think I'm proud of professions, but it's what they put on the table that matters, not what they ask of others. And so the kind of professional leadership that I think will overcome the viscosity you're talking about would be professions that say, we'll change too. And I think that's happening. You're seeing slowly in some of the professional societies a movement toward an understanding that the physician, the nurse, the pharmacist, the health administrator, the industrial engineer in healthcare is in a system that needs to change, and they need to be citizens of that change, not resistors. You're able to do that. I can see it in your faces, and that will really help when you ante up first. It happened 2 weeks ago. A real turning point, April 4th, the American Board of Internal Medicine Foundation, as you know, has convened the Choosing Wisely campaign, and 9 specialty societies on April 4th issued guidelines, their own statements of overused procedures in their own specialty, things that less should be done of. And we now have specialists like gastroenterologists saying too many colonoscopies and endoscopies. We had cardiologists saying too many stress tests, and echocardiograms and Gallium scans. So they're visibly active to the stewardship of public and private resources against their own self-interest. That is massive. When the professions start to say patient comes first that way, I think we stand a good chance of turning that around.
Hi, I'm Basim Khan, a primary care provider at a community health center close by. I've seen you speak before and draw great inspiration from you. And my question is, how do you sell a vision of what healthcare ought to be like, or how we should approach health in general? You've obviously been doing this for a long time, and I just want to hear your reflections on the response that you receive amidst so much fear from people about losing what they already have.
You heard it from Marshall Gantz last night, if you were with him. I wasn't, but I know what he said. It just starts from you. I mean, you have, as every individual in this room has yourself or a loved one or a friend who needs a fair shake in healthcare. And that's the story it starts with. It's just, you know, it's so easy in some ways to describe the healthcare system we need. It's what you want. And I think if you have the confidence to build from that experience, that'll really help. And then what you're doing with DFA, you know, you do it together. It's really from the heart. That's what people need. I had this interesting experience in CNS. So the polls weren't showing a lot of public support for affordable care, not enough. It's still not where I wish it were. As the public realizes the benefits they're going to get from the Affordable Care Act, that will absolutely change. And if it's taken down, it's going to change fast because people will see what they've lost. But I, as administrator, I went around the country, I visited every region. Whenever I went to a region, I asked if I could please meet with a senior center or some group of patients and families. And generally, that was set up, and over and over again, the same thing happened. Walking into a room with a crowd this size, as administrator, saying, "What are you worried about? Tell me what's on your minds. You know, well, will I lose my doctor? Will I? You know, what are you going to take away from me? You know, they tell me that." And then some scenario will play out. Then you just stop for a second, saying, "This is Williams. What is on? Tell me what it's about." And she would say, "Well, I have 5 doctors. I'm on 6 medications, and I'm not sure these doctors are talking to each other, and someone's going to forget the medicine I'm on." And I say, "Well, Ms. Williams, let me describe what coordinated, seamless care is for you. Let me describe what an electronic record could do for you. Let me describe how doctor number 1 now can talk to doctor number 2. All I have to do is describe the experience, and I think if you work from that platform, you're at a very, very strong place. That's the best advice I can give you. You're one conversation away from it. Yes.
Hi, my name is Marina Hall. I'm a pediatrician at Children's Hospital in Boston. I had 2 questions. One is that, and this is a question that's off the record, but yeah, there was an article by Kaiser Health News talking about the cost of children's hospitals and the fact that they're pretty high cost institutions, and do they really deliver on what they're charging? And certainly in Massachusetts, if you look at the two highest cost hospital systems as partners in Children's Hospital are far and above other hospitals. And second, so what is your opinion on that, or how would you respond to not just Boston Children's, but other hospital executives who say, well, really, we have a unique population, there are measures for us, how can you hold us accountable to those costs? And then also, what would you say to the average Joe pediatrician who says, well, we're already doing the right thing, but we don't have, our outcomes are 20, 30 years down the line, so how do we justify what we're doing when we're being asked to show our value in a shorter term?
Well, let me unpack your question into two layers. I'm not sure I can do this from memory, but I think Vivek heard me say when I took the job at CMS, I actually declined it several times. I didn't know how they wanted a pediatrician to run the $1 trillion agency. My family said, it's $1 trillion, take it. Wait a minute, that's a good job. But then when I was in the interview and talking to people on the wall of the Humphrey building, is chiseled the quote from Hubert Humphrey when they dedicated the building in 1977. It goes something like this: the moral test of government is its ability to protect people in the dawn of life, children, people in the twilight of life, the aged, and people in the shadows of life, the sick, the disabled, the impoverished. That's right, if you ask me. Maybe that's just a political point of view, but I think it's about the people in the dawn of life, the shadows of life, the twilight of life, where they're to protect them, and the rest of us, that they come first. So children come pretty high on the list. They don't vote, they don't make donations to political parties, and unless the people with influence speak for them, they're not going to be helped. So on the philosophical side, yeah. So let's make sure that kids are well off in our nation. Now let's talk children's hospitals. Children's hospitals is a different topic from kids. What I'd say to that is, I'm the faculty or was in the children's hospital, and I deeply respect it, but nobody gets a free pass. Nobody gets a free pass. If we're going to have better care, better health, and lower cost, then everybody produces better care, better health, and lower cost. So what I would say to children's hospitals or cancer hospitals or inner city medical centers or the top 7 clinics in the country is you got to be part of the action. What's needed is better care, better health, and lower cost, and we've all got to be in that game. And that's my response. Do I believe that it's possible to have better care at lower cost throughout the system? Almost without exception, yes. Amazing story I heard about last week, or heard again about it last week. I was at the IHI International Forum with 2,700 people from 76 countries working on improvement. Jönköping, Sweden, a county in Sweden, a man named Christian, engineer at Saab Motor Company, got glomerulonephritis, went into renal failure, chronic renal failure, and had to go on dialysis. Well, Christian's an engineer, so as he got onto his hemodialysis, he started asking the nurses, can't I do it? Can I please do my own dialysis? Because of the culture they're in, they said yes. And so Christian started doing his own dialysis. And the woman in the bed next to him once said, could you teach me? And he taught her. Now, 4 years later, 60% of the patients in that region are doing their own hemodialysis. They reduced the cost 50%, and guess what's happened to complications? They dropped immensely. The highest technology, the best places can still think hard about innovations that will change, and that's my answer to that. Yes? Back here.
So CMS is leading the way on looking for ways to quality, lower cost. Can we do this without participation from private insurers? Because they theoretically could have stepped in and done this at any point in the previous several decades. Are they participating? Sort of, how's that going?
You know, if there ever was a time when one major party could do it alone, and probably there wasn't, it's over now. That we're in it together, we're not in it at all. And the answer to your question is no, it has to be everyone together. The good news is, you're generous to say CMS is leading the way. There's plenty of some wonderful stuff going on there. Again, a lot of it's supported by the Affordable Care Act, but even without that, but they're not alone. And I can name areas of progress where the private sector insurers, private sector delivery systems are ahead of CMS, and it's this wonderful dance of progress that I think is an engine that's in the system right now. And my main theme, one of my main themes as CMS administrator was, well, the vision statement I had for the agency was this: it's that we will be a major force and a trustworthy partner for the continual improvement of health and healthcare for all Americans. That's a complex sentence, but major force meant proactivity. But a trustworthy partner was key, because I know there's so many out there that want to work together with us. And I think the ethos we should be progressing is we're in it together, we're all in it. And you'll find lots of parties out there that want to participate, including private sector payers.
As one pediatrician here in DC, when I'm feeling despondent about our healthcare system, I watch videos of you on YouTube.
Did you ever hear the story about the optimist and the pessimist? The optimist says to the pessimist, you know, optimists live a lot longer. And the pessimist says, serves them right.
Well, one thing that Marshall Gans said last night is that those in power need to be pushed by advocates from the outside. And so I'm both curious to hear what the reality is like to be the administrator of CMS, and the kind of challenges and kind of daily frustrations that you face, and kind of the reality of that position, but also to hear within that where it's helpful to be pushed by groups like this.
Well, I'll start at the end. It is immensely helpful to be pushed by groups like this. There's a lot of reasons for that. One is that's how politics works. That there's a consideration always in the air, at least inside the Beltway. I don't know about state houses; they count as well. But it's like, who will care? Who, and not who do you imagine will care? Who do we know cares? Who's writing? Who's speaking up? It's very, very active. It's every day. It's not a theoretic thing. It's democracy, I guess. But if you stay silent, don't expect democracy to work. So I would say, please don't underestimate your power. Do not underestimate your power. Vocal support for the stuff you care about that you think is right is essential to progress. As administrator, I mean, it's an amazing job. It's by far the best job I ever could have had. I loved it. But it was a matter of forces, the force fields, the Congress, the White House, the lobbyists, the press, my own staff, the secretary, different people coming at you with different legitimate needs. It's just very exciting to go through that balancing job and trying to produce a really, really good product or output. The glory of the staff, 5,000 people in CMS, it's always true in any large organization, the vast majority of whom just want to be proud of their work. They want to do a good job. And you just tell them what hill to take, and then they start taking it. And it's an amazing thing to see. But when politics enters, and that tough call has to be made, do we go with this issue or not? Do we write an edgy rule or a soft one? Do we put a stake in the ground or move our stake? That's going to depend on who's being vocal. So this is essential to progress in our country. We need to be vocal. Remember, in healthcare, we have a paradoxical influence setup, which is that the status quo isn't working for the vast majority of people. But the status quo consists of a collection of individual self-interests, which are generally very articulate, well-funded, and by the way, honest in the sense that they're saying that they believe in what they do. So how do you mobilize a vast majority interest in significant change against a collection of very, very skilled individual voices? And it's hard, but mobilization is, I think, exactly the right thing. And the majority who benefit from healthcare that's better, at lower cost, is most of us. Think about that. Better care, better health, lower cost. Who's better off? Patients, families, communities, taxpayers, businesses are better off. Physicians and nurses and pharmacists are better off because they have more meaning in their work. You got this by the short hairs if you get the message out to the people who benefit, because they're the overwhelming number.
which in a way gets back to the children's hospitals. There are many people, particularly on the left, who think the only real way in the long run to control medical care costs is for Medicare and for public payers to use government's pricing power much more explicitly and aggressively to basically force down prices. And in places that have controlled costs, that's basically what they've done. The delivery reform is admirable for all kinds of reasons, but we don't really have in the public record proof that we can reduce costs except by lowering prices. Wondering what your comment would be on that general argument.
I wrote an article that appeared in JAMA last week on cost reduction, waste reduction in healthcare. And this comes not just from recent experience, but from my 30 years of work on quality. And I could be wrong. I'm not totally sure I'm right, but I think that healthcare is a complex endeavor, a lot of interdependency, a lot of moving parts, has within it the same potential for reducing costs through improvement that all other industries have. The hallmark idea in the world of technical improvement is really simple, which is need. If you need, you will reduce costs. I know that sounds kind of zen, but it has you think about what are all the things I'm spending money on that need no needs. So this article picks 6 of them. We call them wedges. The first is overtreatment. It's everything done to people that can't possibly help us. Just antibiotics for viral infections and images instead of watchful waiting. That list is very long. The second is failures of coordination. That NUCA system that reduces hospitalization 50%, the way they do that is they work as a team. When they're a team, people stay home instead of in the hospital. The third is failures of execution. That is, we know how to virtually eliminate pressure ulcers, eliminate central line bacteremia, eliminate 80% medication errors anyway. There's a list of things that go wrong because we're not reliable. We could be reliable. The fourth area was administrative complexity, where we just have a very complex system. Ask any doctor in his practice or a nurse in the wards. We're layering in costs that don't add any value. The fifth is the one year after, which is pricing failures, where we don't commodity price commodities in healthcare. We boutique price commodities. We pay 5, 10 times as much for MRIs and CT scans and procedures in America as they do in other countries, and that's not because they're that much better. It's because we don't have an active set of market circumstances to bring those prices down. And the last is fraud. It's unfortunately quite pervasive. In some parts of the country, it's massive, and we need to nail it. Well, my colleague and I, Andy Hackworth, and I, who wrote the article with me, we did a vast literature search for the magnitude there, and the lowest number we can come up with for the sum total of just those 6 sources of waste is 20%, 21% of healthcare costs in the country. The upper limit is 47%, the median is 34%. 1 out of $3 spent in American healthcare is completely wasted on those. Now, we could go ahead and just cut budgets and slash payments. That would be pretty blunt, as opposed to a professionally led, well-embraced effort to actually get at those sources of waste. I really believe that that's a way to preserve the care we want. Yes, ma'am?
Sorry. I'm sorry. Can I go?
Thanks. I'm Evan Salino, I'm a county physician from Portland, Oregon, and you've definitely been an inspiration for all that's going on in Oregon. I have 2 kind of tough questions. You have to talk about stewardship and pricing. So what do we do to get rid of the RUC, which for those people who don't know actually sets the pricing for how medical care works, and it's doctors, 25 doctors, 3 primary care docs, a secretive process that nobody knows what happens, and we set the pricing that Medicare then accepts and private insurance accepts. How do we get rid of that process and come up with something that is more transparent? And the second tough question is, if the Supreme Court unfortunately strikes down the individual mandate, what is the best policy solution to fix that?
2 tough questions. Well, the RUC is a legacy system of attaching payment to work. It's based on the resource-based relative value scale work that was done at Harvard years ago. When we were in a fee-for-service environment, when the idea was to pay people for inputs. As long as we're in an input-based payment scheme where you get paid for how much you do, you've got to have some arbiter of how much you pay for each of those elements. I think there could be better systems than the RUC for sure. I must say, I met with the RUC leadership. I think they're trying to think of new ways to approach their tasks. They're trying to be more transparent. CMS itself has been much less a rubber stamp. I think the number of RUC recommendations has been accepted has fallen. If I remember the numbers, from about 95% down into the 70s. So there's progress there. But the actual fundamental is that we are in a healthcare system that pays for how much you do instead of how well you do. It pays for how many things you do instead of how well the patient does. And it doesn't aggregate payment across time and space, so it actually pays for little pieces. That's the RUC is simply the tip of that iceberg. As we move toward more rational payment systems, which really do help me coordinate the care for my patient and put a premium on how well the patient is doing. I don't think it's so much as incentive as giving me the resources to orchestrate care. I think we can free ourselves from the bonds of that legacy system. The second question was?
What do we do with the individual mandates?
Yeah, individual mandate. Well, I'm still thinking it won't fall. I know I'm in smaller, maybe not small company, but there's a lot of disagreement about it, so I hope we're not going to have to face that. And the answer is I'm really not sure. I think that the logic behind the connection between individual mandate and guaranteed issue and community rating, that's the three-part stool that allows us to make healthcare a human right, they're logically very connected. The different experts in the field have many different estimates of how much unraveling would occur if the mandate falls, but I think the mandate is it's a necessary and good idea in which people bear responsibility for playing in a national system of care. The thing I do notice is how much of the Affordable Care Act still is there that's not connected to that healthcare as a human right piece. Making healthcare a human right seems to be crucial, and this is a big step toward it. But in the Affordable Care Act, there are many other elements like the Innovation Center that's funding a lot of very interesting work on continuity and excellence in care and prevention. There are prevention things funded. There are all these new forms of payment, bundled payment, accountable care organizations, medical homes, health homes, community-based care transitions. Those are not logically necessarily connected to the mandate. It will be up to the Supreme Court as to how much of the law they go after, if they go after any of it at all. But the law is a very textured law with many, many important elements to it. The most important of which is extension of coverage, but it's not. Yes, ma'am.
Heidi Foley from Massachusetts. So we hear a lot about what we as doctors need to do to make healthcare better. And I ask this question of many politicians that I've talked to. A lot of it starts at home, and it starts at school. And when my kids are being fed for lunch peanut butter and fluff on white bread, and there's no PE in the school, and mom's on food stamps and can't afford fruits and vegetables, and all they eat is potato chips for dinner, I can't win. So CMS can't really innovate how to make, I don't even know who covers food stamps, but when are the different agencies in DC going to communicate and work on those problems as a group and not just piecemeal it, because I can't win if all they can afford is soda pop has replaced milk at the schools where I am. I can't win.
Yeah, well, I mean, point's absolutely right and very well taken. Maybe the only thing I'd add to it is that there is cause some optimism here too. My agenda at CMS was the three-part aim, the triple aim, better care, better health, and lower cost that Vivek mentioned. Better health is part of that. And perfecting an American, a nation which is fundamentally on a journey of health is going to have to bring us outside healthcare into everything we just talked about in terms of the circumstances that lead to illness in our lives. The science is clear. It's that of the variation in health status, 10% attributable to healthcare, 50% to genetics, and 40% to everything else you just listed. The work of David Kindig at the University of Wisconsin is fundamental here. If you haven't seen his community health rankings, please go there because it's a breakthrough ability to look through that window of healthcare. Now, the Affordable Care Act, which is the statutory foundation we've got right now, has investments here. There are investments in prevention that are very much under attack. There are And think about this, that an organization like, let's say, an accountable care organization that becomes real is going to be quite interested in the same problems you're talking about. What is making these people have their chronic lung disease or their heart attacks that's costing us so very much? So the momentum is there. The same thing applies, as I said before, the professional leadership, your ability to speak up and say, this is not down the street in the annex, this is central to our mission, it's going to be absolutely key. There are agencies that have assignments in affordable care that are very important. Agencies, assignments around much more nutritional information available, prevention support for the Centers for Disease Control, the Expansion Community Health Center work in HRSA. So it's all there, And let me reassure you, the first word I heard when I interviewed for the CMS job was teamwork. We are a team, and it's real. Those agencies are in the room together, and there were many, many very promising interactions now about how we can help each other. If we keep on that trajectory, we'll see better cooperation than we've ever seen before. It's not easy. We've got a long way to go, but we're on good. Yes.
Josh Oppenheimer, I'm a medical student at Mount Sinai. And I think one thing that we can all agree on is that improving the quality of our healthcare and changing our incentives so that we are paying for the quality of delivery is something that we're rallying behind. But unfortunately, as you said, there's also an aspect of fraud within our system that is not likely to change. So when we begin paying physicians based on quality metrics and based on their ability to lower the cost of the patient's care, unfortunately, there are going to be some bad actors who do cherry-pick patients and who do deny care. And so how do we respond when that happens, and how do we avoid these wonderful ideas from being tainted by those people who don't act appropriately?
Yeah, I don't want to be naive in answering your question. This idea of us bearing responsibility for that very, very tiny number of people in the system that are actually polluting things for everybody, we have got to find ways to do that. And as you become members of your state medical societies, you participate in the governance, local governance in your organizations, speaking with confidence and direction about what is not acceptable is important too. Be really careful. This is a tiny portion of caregivers. Most of us are fine. But these ruin a lot for others, so I'd say you need to be part of that action. Again, I hate to keep mentioning the Affordable Care Act, but there is a tremendous amount in that law that allows the government to be much more skillful and diligent in pursuit of that action. And for example, while I was there, a contract was signed with, I think it was Northrop Grumman, to use kind of the same surveillance, like if you were to go to Turkey tomorrow and on vacation and use your credit card to buy something, you get a call from your credit card company perhaps saying, are you really in Turkey? The same, they call that predictive analytics. CMS can do the same thing, and it's underway. I think we'll get this under control, but professionals need their responsibility for behavior of the professionals. Yes. Someone back here?
Yeah.
There's so much emphasis on cost cutting. I feel a little intimidated to even bring up whether there's any talk about bringing more money into the system, into the healthcare system. For example, the Mayo Clinic works so well because it's a great institution, but also because of medical tourism from Saudi Arabia. And it seems to me that part of the problem is that there's just not enough money in the system. One of the areas of growth in the economy right now is the exportation of consultation expertise, in particular information technology. But I think there are countries in the world where there's a growing middle class, and more than information technology, they would value healthcare knowledge. American medicine is still the best regarded in the world, even if it's mired in a dysfunctional delivery system. We are borrowing all this money from China. Why not give them something in return so that they can buy? And so, in any case, I'm just wondering, every large corporation now has an Asia strategy to survive. The healthcare economy, what does it have a strategy to
without getting into too much detail, so I think that the attitude that helps most is an attitude of abundance. Not to notice how little we have, but to notice how much we have. The imaginations of the whole workforce, the inventions of the NUCA, or I could tell you 10 other places that are inventing things. We are really very, very wealthy in American healthcare. And yes, there are pockets that need more, but I think we can use our cleverness to do far, far better with what we have. Now, the structure that I always use to think about this, take 1 minute to explain, it comes from a scholar named Noriaki Kano, Professor Kano's in Tokyo. Kano says, look, at any point in any industry, you can always do 3 kinds of improvement. Kano 1 is you can always reduce an defect. You can make the car start every time. You can make the Gorilla Glass survive when you drop your iPhone. You can prevent a pressure ulcer or infection. Kano 1, prevent defects, do that. Kano 2 is you can always take costs out. No matter how you're doing it today, there is a way to remove some element of waste or excess cost from your procedure. We know that. It's just a property of the way complex systems work. Reduce cost while holding the patient or the customer completely okay. And the third is invent something new. Invent sunroofs in cars. It's not a defect. No one ever drove their car around saying it's a terrible car, I can't see the sky. But someone thought of sunroofs, and that is a good thing to add to a car. So is a new capability in a pacemaker or a telemedicine opportunity. That may raise costs and do better things. But the point is, a mature industry is interested in all 3 and notices at any point in time which kind of improvement is most salient right now, the one that's going to get us to the social need. And like it or not, the improvement right now that healthcare needs more than any other is Kano 2. It's ways to do things even better with less resource. So don't ever abandon the inventions that you're talking about. Indeed, we'll fund them by finding the ways. But I think confidence in the professional community that we can find a less costly way to do this and the patient will be just fine is absolutely essential right now, and it is true. Yes, sir.
You have heard this many, many times, but I'll say it again. Thank